One of the most common questions I'm asked is which is the best lens for cataract surgery or refractive lens exchange. The honest answer is that there's no single best lens for either of those procedures. There's only the lens that's the most appropriate for the individual, and that depends on their lifestyle, their preferences, what they're willing to accept as a compromise. And a more expensive lens is not always necessarily the best lens. And the lens that offers the most range of vision isn't always the best lens either. In this video, I'll explain what the different lens types are, what the advantages and disadvantages are for each one of those, and how we actually decide which lens to choose. I will say that this is for general informational purposes only. The best decision for the individual can only really be made after a detailed assessment of their eyes and of their preferences. During cataract surgery or refractive lens exchange, the natural lens in the eye is removed and replaced with an artificial lens. The surgery itself only takes a short amount of time, usually anywhere from about 10 to 15 minutes on average, but the lens choice requires careful thought. This is because the artificial lens does not behave like the natural lens. Now when we're young, our natural lens is flexible, so we're able to see in the distance as well as close up without glasses. But when we get older, usually in our 40s and 50s, that ability to see close up starts to diminish, and that's what we call presbyopia. Now, an artificial lens has fixed optical properties, and different lenses tend to provide different ranges of vision, but each lens design has its own strengths and limitations. So the lens choice isn't simply about selecting the most advanced lens. It's about deciding which visual qualities matter the most to you and which compromises are least likely to bother you. Now, before discussing which lens technology or lens brand I use with the patient, I first want to understand what their lifestyle is like. So are they somebody who drives a lot at night? Is this someone who spends several hours a day reading? What are they reading? Is it a book or a Kindle? Is this somebody who's sewing, using fine tools? Are they a watchmaker? So essentially how much time they require for different activities. Do they use a lot of computer work? It's only after I've established what sort of preferences they have is that I'm able to make a decision with regards to what lens is appropriate. So two patients may actually be exactly the same age. They may have a similar prescription, they may have very similar eyes, but depending on what their hobbies and preferences are, we may go for a completely different lens depending on what's most appropriate for them. Neither of those is wrong. It's just about what's the best match for the individual and their lifestyle. So for example, one patient may be quite keen to prioritize sharpest vision and as well as being able to drive at night. Another patient may be very interested in having the most range of vision possible and being able to read, but they may not be that worried about experiencing glare and halo, especially if they're driving in the dark. So neither of those patients is wrong. The decision primarily just depends on what's the most important to the individual. So let's start with the monofocal lenses. A monofocal lens is designed to provide excellent distance at a single focus point. So most of the time the two eyes are targeted for distance. So it provides very good distance visions for activities like driving, watching TV. However, because the focal point is set for distance, they do require help for tasks like reading and close-up work. One main advantage is that there's not as much in terms of glare and halos, especially when driving in the dark. So for example, if somebody is quite sensitive to starburst, glare and a phenomenon like that, especially when driving at night, this may actually be the most appropriate and satisfying option for them. As I said, the main trade-off here is that they will need to wear glasses for close-up work like reading. So choosing a monofocal lens doesn't necessarily mean that it's an inferior option. For the right patient, this may actually be the best and most satisfying option. And as I said, the main limitation is that it does not provide the full range of vision without the need of glasses. Now, one way to increase the range of focus with monofocal lenses is to use a technique called monovision or mini monovision. Essentially what that involves is that the dominant eye is set for distance and the non-dominant eye is left a little bit short-sighted. And what that does is that it allows the brain to combine information from the two eyes and gives good distance vision, as well as allows some tasks that require intermediate vision, so things like working on a computer, looking at a dashboard in the car, and things like that. So the advantage is that we have monofocal optical design lenses, which are increasing the range of focus without us having to rely on a multifocal optical design. There are, however, trade-offs though as well. So, for example, the eye that's left slightly short-sighted is not as good for distance. The individual may still require glasses for reading small print. And not everybody actually adapts to the monovision well. They don't like the two eyes having a slightly different focal point. So it's important to choose the degree of monovision carefully and match it to the individual's requirements. And it does actually work very well in some patients. So for example, some patients use contact lenses to achieve monovision and they manage very well with it. So for someone like that, it can be an excellent option. But for others, it may not be appropriate. Now, there are lenses sometimes described as enhanced monofocal or monofocal plus lenses. These lenses aim to provide similar visual quality as a monofocal lens, while also increasing the range of vision and providing a little bit of intermediate vision. So like looking at a dashboard in the car or looking at an object at an arm's length working on a computer. It's worth mentioning though that the word enhanced or monofocal plus shouldn't be misunderstood. The individual still requires glasses for small print and for near work. They don't provide the same range of vision as a multifocal or a trifocal lens does, for example. But it can actually be a very good option for somebody who prioritizes visual quality and is happy with some intermediate vision and does not mind wearing glasses for reading or close-up work. Again, they are not automatically better than a monofocal lens. They just offer a slightly different balance. EDOF stands for extended depth of focus. These lenses are designed to extend the range of useful vision from distance towards intermediate. And patients some of the time are also able to achieve functional near vision as well. However, small print may still require glasses to read. These lenses are a very good option for somebody who wants excellent distance and computer vision, but they still don't mind wearing glasses for very small print. Compared to a monofocal lens, however, there's a slightly higher risk of glare, halos, starburst, and phenomenon like that. And this depends on the eye of the patient and the lens type that's been chosen. It's worth mentioning, however, that these phenomena like glare and halos are not as prominent with these lenses as they are with the traditional multifocal or a trifocal lens. So essentially, it doesn't mean that the EDOF lens is free of any compromise. It's just that the compromise sits in a slightly different place. So the patient will gain more range of vision compared to a monofocal lens, but they will not have as much range of vision as someone with a multifocal lens, for instance. Multifocal and trifocal lenses are designed to provide vision at various different focal points. So essentially they aim to provide distance, intermediate and near vision. For the appropriately selected patients, these lenses can significantly reduce dependence on glasses. But I will reiterate the word significantly reduce dependence on glasses. No responsible surgeon will ever promise that the person will never need glasses again for any tasks, because even with these lenses, so some patients may still prefer to wear glasses for certain situations. So especially if they're working in low light conditions, they're reading very, very fine print for a prolonged period of time, or if they're doing any particular specialist task. And the way multifocal lenses work is that they divide the light or split the light to create multiple different focal points. This does increase the range of focus for the individual, but it also produces side effects like glare and halos, especially in the dark. And it can reduce the contrast sensitivity, or in other words, it can make things appear a little bit dimmer. Now, many patients adapt very well to these side effects. If you look at the Royal College guidelines, then over 95% of individuals tend to be happy with them. There is a minority of patients, though, however, who find these side effects quite intrusive. Unfortunately, there's no test which can determine which person will be particularly sensitive to these side effects and who will tolerate them very well. Again, the personality can make a difference. Again, patient selection matters enormously here. So someone, for example, if they are driving a lot at night, they have very high visual demands, or they are troubled by even the smallest imperfections, they may not be the appropriate candidate for this. The goal is to identify patients in whom the visual benefits justify the optical trade-offs. The lifestyle of the patient is important, but it's not the only thing we base our lens decision on. So the health of the eye is also very important. So when we assess somebody, we look at various different things. So we assess the tear film at the front of the eye, the cornea, which is a clear window at the front. We assess the health of the macula, which is at the back of the eye, the nerve, and the rest of the eye as well. Now, there are various conditions which can affect different parts of the eye. So, for instance, if someone has dry eyes, or if they have glaucoma, or irregularity of the cornea, they have a condition that affects the retina. Then in the presence of these conditions, using a lens like a multifocal lens can actually enhance the limitations. So they can actually end up with worse vision or more unsatisfying vision with a multifocal lens than they would with a more appropriate lens choice for them. Now, this does not necessarily mean that they cannot have surgery. It just means that we have to factor those things into the decision making and choose a more appropriate lens for them. That's likely to provide them with a more reliable and more satisfying visual quality. And that's why it's very important to undertake a detailed examination of the eye, as well as the expectations of the individual into account before deciding on the lens. And remember, a premium lens cannot compensate for an unhealthy eye, and sophisticated lens technology does not necessarily replace clinical judgment. The surface of the eye also affects the measurements used to calculate the lens. So if someone has dry eyes, for instance, they can have variable corneal measurements. This can reduce the accuracy of the lens calculation and therefore the final visual outcome. So sometimes the right decision is not to actually rush into the surgery. It's to treat the ocular surface and the dryness first, and then repeat the measurements and the scans to try and get a more accurate reading. And that can help improve the lens decision. Now, it can feel like a delay, but good surgery starts with good planning. And doing the operation quickly does not mean the same thing as doing it well. Astigmatism means that the front of the eye, the cornea, is shaped more like a rugby ball than a football. Now, if that is not corrected, then it can cause a little bit of visual blurring after the surgery. We can use toric lenses to try and reduce the amount of regular corneal astigmatism. Toric technology can actually be incorporated in monofocal, monofocal plus, EDOF, as well as multifocal lenses. But not every small amount of astigmatism actually needs to be corrected. We consider the degree of astigmatism, the pattern of it, the individual's requirements, as well as the reliability and repeatability of the measurements. Now, we also always explain that the toric lens has to be aligned in a certain way for the individual. Now, most of the times the lenses remain stable, but very rarely the lenses can rotate after the surgery and require repositioning. Again, the decision is based on whether the improvement is likely to be worthwhile for the patient or not. If someone's had corneal laser surgery in the past, like LASIK, PRK or SMILE, it can make lens calculation slightly more complicated. These lasers work by altering the shape of the eye, and that means that the standard calculations that we use can become a little bit less accurate. Now, having said that, it doesn't mean that refractive lens exchange or cataract surgery can't be performed. We just have to use additional formulae to improve our accuracy in these cases. But despite that, it's important to understand that because of the corneal laser in the past, the chances of a residual prescription for glasses after surgery tends to be slightly higher in these individuals. Some of the premium lenses may actually still be appropriate to use in these cases. However, other lenses may not be suitable. It all depends on the health of the eye, the previous treatment, and again, the individual's requirements. It's not a decision that can be made from prescription glasses alone. Again, the quality of the scans as well as the optical system matters quite a lot here. Now, one of the strongest predictors of satisfaction after surgery is not just what the patient can see, it's whether the result actually matches what they were expecting. So someone can have very successful surgery where they can see very well in the distance, but they are very disappointed with how much near vision they have compared to what they say they were promised. In contrast, you can have somebody who's got good distance vision and occasionally needs to wear glasses for reading, and they are very satisfied with the result because it is similar to what was discussed with them before the surgery. That's why I generally discuss likely ranges as opposed to making absolute promises about what someone may be able to see. The aim is to reduce dependence on glasses where appropriate. We cannot guarantee absolute spectacle independence after the surgery. And although the measurements that we use are pretty good, the eyes are biological, so it means that there can be variability in the recovery. So if you imagine someone has two cuts on their skin, they will both often recover slightly differently. So similarly, the two eyes can recover slightly differently. And a small residual prescription can remain even after technically successful surgery. Now, depending on the outcome, some patients may benefit from laser surgery or further lens procedures if appropriate, but for others, the best option may be to simply accept wearing a small prescription afterwards for certain tasks. Patients sometimes ask me what lens would I choose if it was my own eyes. Now, there's no universal answer to this question. So if somebody drives for work at night, the best lens for them would be very different from someone, for instance, who doesn't really drive that much, and their main priority is being able to minimize the need for glasses for reading. So the correct question is not what's the best lens, it's what range of vision do I want, what quality of vision do I need, and what trade-offs I am willing to accept to be able to achieve that. The best consultation isn't the one where the surgeon tells everybody to choose the same lens. It's the one in which the surgeon understands the patient's requirements, examines the eye carefully, and then explains the trade-offs honestly as well. Now, sometimes that can mean a multifocal lens, an EDOF lens, or an enhanced monofocal lens. And sometimes the most appropriate recommendation is simply to have a monofocal lens and to wear glasses for reading. So to summarize, a monofocal lens provides the highest quality vision at one principal distance, with glasses required for vision at other distances. Mini Monovision works by giving the eyes slightly different focal targets, and that extends their range of vision a little bit. An enhanced monofocal lens aims to increase the range of vision by giving distance and some intermediate vision. An EDOF lens also extends a range of vision from distance to intermediate and some variable near vision as well. The multifocal or trifocal lens tends to give the most range of vision with distance, intermediate and near, but it also is the lens where there is the highest risk of glare, halos and reduced contrast as well. A toric lens can be used to correct suitable astigmatism, and none of these lenses can be chosen appropriately without considering the health of the cornea, the tear film, the retina and the nerve at the back of the eye. And I always say the most advanced lens isn't always the best option, the most expensive lens isn't always the best option, the lens providing the most range of vision isn't always the best option. The right lens is the one that offers the most balance for your eyes, your lifestyle, as well as your expectation. In the next video, I'll talk about multifocal and trifocal lenses, who may find them suitable, who may not be appropriate for them, and what to understand about glare, halos, and nighttime driving before making a decision. If you found this explanation helpful, you can subscribe for further balanced information about cataract surgery, vision correction surgery, and corneal conditions. Thank you.